The mitral world is, I think, a little bit harder. And the mitral world also comes in a couple of different flavors. The three most common workups that we'll do are a valve-in-valve mitral TMVR, which is probably the most straightforward. The second one would probably be a valve inside of a prior surgical ring, which is a little bit harder to do. But the hardest one is probably a valve inside of mitral annular calcification, or a valve in MAC. So let me show you the easy one first. And so same program. And so in this case, you can see this bright object here. And if I spin this thing around, that is what a surgical mitral valve looks like. You can kind of change the windowing here. And you can see in the cath lab what angiographically it would look like. And this is actually how we would get all of our fluoroscopic angles for the actual deployment. But the concept is the same in terms of measuring out the size of the annulus. In this case, because there's already a pre-existing structure in there, your annulus that you would measure to determine the size of the valve that you would put in there is the valve that's already in there. That's why this type of procedure or this type of workup is probably the more straightforward one. And so I'm going to basically drop 16 dots on the frame of the pre-existing valve.
You usually know the pathology going in as well?
Yeah, good question. So the question is, do I know the pathology of what's happening? And so I forgot to show you guys, but let me show you that. So yes, I always look to see why we're thinking about fixing the valve. So if you look at this picture right here, as I scroll through, what you're going to see is you can see the leaflets, right? There's a leaflet here, a leaflet here, a leaflet here, and these are the commissures of the leaflets, right? And here are the posts of the valve. And what you see is you're going to see some bright stuff right here. And I think over here as well. And I'll just kind of scroll through a little bit. And what that is calcium. And so this is like a 15-year-old surgical mitral valve that's just had calcific degeneration over time. And so this patient had pretty bad prosthetic mitral valve stenosis. So if I play this, a little bit harder to see, but this leaflet down here doesn't move at all. And then these two up here are both restricted. And the other thing is just from an orientation standpoint, we usually talk about these in what's called the surgeon's view, which is a echo term. Well, it's actually a surgical term, but we do a lot in TEE, in the TE world. Let me just scroll back up to the valve here. And so what you see here in this top picture is this is your aortic valve right here. And so this is anterior. And then so the other side would be posterior. And then you have the left atrial appendage. In this case, I think it's been closed. It should be over here. And so this is lateral, and then this is medial. So you have A1, A2, A3, P1, P2, P3, which is the common terminology that we use in the echo lab. Anyway, so let me go back to the annulus that we just defined. And so we can make a measurement as to how big this is. The other thing is all of these valves, if you know the type and size of the valve, you will know roughly how big the inner diameter or the true ID of the valve is. In this case, it's measuring, this is not perfect, but it's measuring roughly 23, 24 millimeters across. Some of these mitral valves are what's called fracturable, where what that means is you can put a balloon inside of it and dilate the valve and actually crack the frame so that when you put a valve inside of it, you can overexpand it. And so my guess is that we would probably put a 26 millimeter valve on the inside of it if it's measuring 24 across. So 26, 26. And the valves that we usually put inside are all off-label TAVR valves. So these are all SAPIEN Edwards sapien TAVR valves that we are using in the mitral position. 26 TAVR valve, I think, is 20 in height with a skirt of 10. And so now, in this picture here, you can see what it would roughly look like if we did a valve inside of a valve. The next important thing here, and this is also why the mitral world is a little bit more complicated than the tricuspid world in terms of the actual CT planning components, is that this right here is your aortic valve, right? And so this right here is your left ventricular outflow tract, and obviously here, this is your left ventricle. If you had a really small left ventricle, or if you had a really big valve, or both, this valve, I would never deploy this valve like this, but let's say you did. What it's going to do is it's going to block your left ventricular outflow tract. And so in the TAVR world, I don't know if you guys got to it yet, but the thing that you have to be most careful about is coronary obstruction with these transcatheter valves. In the mitral world, the thing that you worry most about is LVOT obstruction. And so not only do we have to measure the annulus and pick the right size valve, but then we also have to assess for LVOT obstruction. Just visually looking at this, I think we're going to be okay, but let me find my workflow here. But the second step of this is defining your LVOT. If you want to see what the LVOT is going to look like, now what I've essentially done is, rather than scrolling through initially in this other tab, what we were essentially doing was we were scrolling through the axis we were coaxial to the valve and scrolling through the axis of the valve in this picture here, right? And then if I want to see what the LVOT looks like, I define the LVOT, and now I'm scrolling through the LVOT. And so now I'm looking in this top left picture still, but I'm getting to where the LVOT looks the smallest with the valve there. You can see the shadow of the valve in that blue line right there. And so now I can actually trace out this area. And that is how we measure, roughly, we measure what's called the neo-LVOT, or the new LVOT, hypothetically, if you put a valve in there. And the measurement that we want to see is anything over 200, but ideally, well, really it's 180 bare minimum, but really it's anything over 200 makes us more comfortable.